so much is happening, and there's so much information out there, and a lot of noise, that I wanted to provide an overview. I think we should do this once a month or so and understand where we really are. I wanted to provide a perspective, and right now, firstly, I want to thank my staff for producing these slides in the last minute, and also some of the guests that may be on that providing me with information from all over the world, including my friends and colleagues from Korea, Japan, Turkey, and in England in particular, as well as my colleagues across the country. These are not the folks that are YouTubers now with hundreds of thousands of followers providing interviews with other experts. These are people on the ground. So in particular with Dr. Park in Korea, who's more recently taught me how the Koreans are doing so well. So thank you very much. But this is the cumulative data from the first 5 or 6 rows there in Europe versus the United States and versus our Asian colleagues below. And you could see around a 100-fold difference between Asia and the EU. And then we're somewhere in the middle in the United States. We haven't done as well as Germany or Canada, but we have been doing better than our EU colleagues, except to say that at this point, you'll see it a bit in a minute, that our European colleagues are doing significantly better than we are now later on. So early on, they were worse. We were, of course, worse in New York and California, in New York and New Jersey and Connecticut and the East Coast. And you could also see that New York was a one-off thing. There's nowhere close in the United States or Europe for that matter that came close to the epidemic in New York in late March and early April. And so when you look at the peak effects of these countries across Europe versus now, they're down 10, 15-fold by a factor of 10 or 15 or 20 even. And we're down around a factor of 2, 2.5 as compared to our peak in the middle of April. One of the important things on this particular slide is that the country that never went through a formal lockdown did more poorly than us early on, and now is going down as well. So right now we're roughly a little bit lower as a country, but certain regions of the country, including California and New York for that matter now, are below this level. So lockdown is not the only strategy that should be on the table in terms of prevalence and incidence over time. So when you look at the peak effects in the middle of April, so really basically 3 months ago, we would have projected at a daily rate that was going on then of deaths per million, we would have projected 1 million deaths in 2020 over a 12-month period. And it went rapidly down, and over a 2-week period after the East Coast surge, we went down to a projection of this amount. Now, this amount is important because this 650K a year or over 12 months is equivalent to cardiovascular deaths in the United States over 1 year. Then it roughly halved a month later, and then roughly again halved again. The issue is that now we're going a little bit further and we're going back up. And the questions are why and what can we do about it and where the trends really are going. So, oh, I see. So I have the wrong slide deck here because when I switched over to the wrong one. Hold on a second, please.
Yeah. So it seems like some of our attendees are having some technical difficulties. If you guys are experiencing audio issues or anything like that during the webinar, all you have to do is just refresh the browser page, which is at the top of your screen. And if you continue experiencing problems, feel free to reach out to us at the phone number provided that is at the end of all registration emails and webinar notification emails. Our view is back up. Looks great, sir.
So right now we're at 154,000 deaths as of today. That rates to around 400 some odd deaths per million. And today, that means that 1 in every 2,200 people in the United States will cumulatively die this over a 12-month period, which is roughly about 5% of the almost 3 million deaths annually. But when you look at it in comparison to other years, 2017, 18, and 19, there are more cumulative deaths in the flu, pneumonia, COPD category than there are currently. But this is probably an estimate of the equivalence of where we will be at the end of the year. And ultimately, if everything goes the way we expect it to go and where we are today, we'll likely rise to 8%, or 1 in 12 of the deaths in the United States in 2020 will be reflective of some association with COVID-19 versus 650,000 deaths from cardiovascular death and 600,000 from cancer. So then you say, well, we all know that the youngsters are pretty much protected. But look at these numbers. Less than 0.2%, so 0.16%, or 1.6 of every 1,000 COVID deaths occurs in people under the age of 25. And again, it's extraordinarily lower when you get under age 14. And I think we all know this. And this was the first set of clues that were coming even from China back in December or January. So there's a significantly lessened risk when you're in the middle group. But college age or lower, the risks are extraordinarily small. And there's roughly a 600-fold difference between being older and being relatively younger in the United States for this. And we'll get into why, and I think most of you already know some of this, but I'll get into it in much more detail, because we do have to develop a strategy that doesn't involve repeated sets of lockdowns. So we knew back in January and February, based on the data from China, that this is this virus presented with multiple different symptomatology. And one thing that was clear from the very beginning was that the lungs had a predisposition, and then it became clear that the effect was largely due to this particular receptor that the virus held. And this has largely been maintained throughout. Whether the virus is mutating in its form between Asia and Europe and between Asia and the United States is still unclear, but we do know that it involves this particular receptor. And this particular receptor explains the overwhelming majority of the nuances of this virus, and also provides the clues for how to deal with the virus effectively, both antivirally and also from an anti-inflammatory point of view. So here's a little cartoon with the ACE2 receptor. We all know that these are densely occupying all lung cells, all heart cells, and pretty much all cells of the body, but there is an accumulation in the lung in particular. So the virus binds to this and goes through a set of steps. This cartoon I'll show a little bit later. This comes from an article in Lancet that was just recently published, looking at the various different treatments. But this is the basis for the accumulation. And the reason is not because the virus gets into each cell this way and then provides havoc. It's because this receptor is responsible for so many different factors. It has powerful anti-inflammatory and modulating effects. And when the levels are reduced, then these beneficial effects are lost. So when you lower the ACE2 activity, you end up with a lot of inflammation or cytokine storms, as we now know it, in susceptible persons. And the question is, why? Who is susceptible and why? And what does this really mean? So we know from discussions that we have amongst ourselves and listening to the lay press that hypertension, heart disease, diabetes, obesity, COPD for that matter, all of these disorders have a huge inflammatory component, and also a huge component in terms of vascular health. And we know that folks so folks that are doing poorly with this virus end up with an inflammatory state in their lung and inflammatory state in their blood vessels. So these are already predisposed people that have ACE2 deficiencies, and then the virus, as it enters their body and is allowed to sit there unchecked, will then lead to a state that's even worse. So, and that's a tipping point, and that ends up to be when you're seriously ill and you need to be not only hospitalized but put under intensive care, and then at high risk for requiring some kind of pulmonary assistance. So we first were frightened initially by using of things that affect this ACE2 levels, like NSAIDs, like ibuprofen and ACE inhibitors and other antihypertensives, but these do not increase the risk of infection at all. So now it's clear that if and when you get this virus, then it's how you're able to control your response that will dictate whether you remain asymptomatic or very minimally asymptomatic, or you end up to be life-threateningly ill. So this comes from data from New York, when New York was almost reaching its peak. New York reached its peak death rates in the 17th, I think, of April, around the month after Governor Cuomo did the lockdown, and the mayor Blasio did the lockdown a little bit too late for that matter, but they did it around a month earlier. But it was clear from several thousand people that everyone in this pie chart had, in every age group, whether you're above 75 or 65 or 45 to 64 or whatever, the majority of them had pre-existing conditions. And the reality is that 80% of people have multiple pre-existing conditions with this, and then 80% of folks, if you combine 47 and 24, you end up with 70 some odd percent, 70, 80% of them are above the age of 65. Now, I was in a discussion with Howie earlier before we got on as to what the leading data are. When it first came out, we had Chinese data, then data from Europe, and now more recent information from the CDC. Half the persons have hypertension and half the people are obese. And then you have a series of these other illnesses. Now, when you look at these, all of them in the top 6, and then asthma and other things, are all inflammatory states. Renal disease is not a good thing to have as a pre-existing condition, because with a very high mortality rate, and that's because you're probably on dialysis and in a weakened state. But ultimately, most of these states are inflammatory, and yet there's a few other little subtle points here. One of them is you'd think that if you were immunosuppressed and you got exposed to a virus, that you would be really at very, very high risk. And yet only 9% of people do have that category. And that reflects the fact that most immunosuppressed patients in the United States are on chemo, and they're more at risk for bacterial and fungal disease than they are viruses. And then when you get really sick from this virus, you're inflammatory, but these folks can't mount an immune reaction as vigorous as quote unquote normal people, or people who can go into a hyperinflammatory state. So it's an interesting vagary of this, but the majority of cases are already inflamed people, and then they get this trigger, so to speak, that puts them out of control. So then this is shows a 5-fold difference between Caucasian white people in terms of hospitalization rates as of over the 4-month period versus darker skinned people. And this is not only socioeconomic, and not only that, but this correlates beautifully with the more recent data exploring the role of vitamin D. Vitamin D is much lower, significantly lower in this population at the highest rate of hospitalization, and that is such a potent immune modulator that we typically forget about because it's not sexy and it's not expensive, but this correlates beautifully, linearly, with the reality that folks that have pre-existing conditions, that live in high-risk environments and work in high-risk environments and also have vitamin D deficiency are at particular risk. I'm going to skip this because, but I do want to say just a few words here. When we first started, this left panel is in early April, and things were really just not even happening that much in the U.S. versus overwhelming reactions in Europe. The scale here is 300, if you know. Here the scale is triple. So we go up from 30 to 464, which is the data as of today. So we've gone up right 12, almost 15 times, whereas the Europeans have gone up 2 or 3 times, and that's because they peaked when they were peaking here, and then have slipped down and down since then. And we are we have risen and then have been relatively stable until the last few weeks when we're going up again. So the question is where are we? Because I think you can roughly say that most of the news today, maybe 90% of the news today is focused on this virus. And then you have other folks that's calling it hoaxes and other folks that calling it conspiratorial and so on. And I think it's difficult. You have to make up your own minds, but I do think it's important to have a perspective. And worldwide, there are 5.8 million cases, and the WHO and the Hopkins database considers that 1% of those cases are serious. So right now, there are 10%. For every 10 people that we test in the United States, we get a positive case on average throughout the United States. So, and of those that test positive, then we have, a very low proportion of them are considered to be serious. There's no definition given by Hopkins, the World Meter database, so we don't know. And the same, and roughly these are the 3 countries that occupy half of all serious cases in the world today. And of course, we lead them, but we have a higher population than Brazil, and of course India. We cannot really think that data are necessarily accurate. But right now, the data in the world basically tracks what's going on in the United States, where less than 1% of the cases are considered to be serious. So at the peak, you had these extraordinarily high levels, and now they're 100-fold less. This is 150-fold less. This is 14 times less. So these countries have largely put their hospitalizations and death rates under control. Sweden is now significantly equivalent to the United Kingdom, despite never going under lockdown. And this is, I'm really hopeful that people will tease this out over time, over the next 6 to 12 months, and understand all the reasons why this is the case. But this argues at least a reasonable argument to suggest that there are alternative options. We don't have any idea whether herd immunity has been reached in any location, anywhere in the world at this point. But that was the goal of the epidemiology persons that were running the healthcare decision-making in Sweden at the time. But we are roughly half of where we were, rather than a logarithmic level lower. So I was showing you the slide that slide was not up to date. So actually the data are look like this. So 800K to start with at the 415 mark, mid-April mark, and then 2 weeks later was 660, and then roughly it goes down by half every month. And now this month it's going back up. So this is causing the current news cycle is all about this spike, and all about all the different people we can blame for this, and all the different pathology causing it. But I do want to tease out each of the individual pieces for us so we can make coherent decisions going forward. So this is where we were this is CDC, data from the World Meter Hopkins database, but this was over the first roughly a little bit less than the 2 months, and we peaked very, very high in these 3 states. Massachusetts then peaked later, But these three states are all roughly 1,000 or more cases per million. This is higher than any of the European countries ever were, and it was concentrated in a pretty significant part of the population. And there was, most of the time when it first started, both New York and New Jersey roughly occupied all 40% of all the deaths in the United States. And then it got under control because they overwhelmed the system. And that was the whole point of all the flattening of the curve and all the lockdowns. The fundamental reason for it was to protect the healthcare system from being overwhelmed. And finally, that took hold, and the cases started to drop dramatically over the next month or two. And then starting in June, remember, Memorial Day was the first time we sort of, almost everyone in the country sort of opened up just a bit. Some states opened up well before then. But you notice that for the month of June, even the states that are later going up and up, not as dramatically as the East Coast did in the early part, but just going up, well, they remained flat in June. So there was a month period that essentially not much was going on, but things were building, because, as you know, in order for you to get to actually die of this illness, it can take 3 to 6 weeks. So this is an important fact of life right now, and understanding the profound importance of getting this thing under control right now in the same way we've done in the past. So right now, as of a few days ago, 5 states occupied roughly half the total US deaths, and here they are. But at the rate of 950 cases a day, if you do that for the population of these 5 states, and you said, well, let's say the whole United States was at this level. Well, if that was the case, we would have more deaths from COVID than we do from heart disease, which is untenable, of course, and not realistic. But if we then went down to the rest of the country, the other 45 states, and realized that population is much larger and the prevalence rates are much lower, then for the entire year we'd have a much more manageable number that we were more likely not to be anticipated. Now, this number is higher than a typical flu season, and I'll relay that in a minute, but it is not nowhere close to where we could be if we were at the same rate as the current surge levels are in those states. And realizing that those states are not uniform, and there are regions within every state that are much higher than others. So this is the way I would like the group to begin thinking about this. I want to think about it in a 2-month projection. And so, because when you study the early surge and you realize where we were a month later, we were roughly at half. So if we went a month from now at half the deaths, for a number of reasons, not only because it's a natural history, but because, as you'll see in a few minutes, our treatment protocols are improving dramatically across the country. So if we went down half the deaths, we'd end up at this rate. And if we went down another half set of deaths in another month, we'd be at this rate. And I'll show you just recently, in the next slide, this rate is not dramatically different than one of the worst flu seasons we've recently had a few years ago. Now, if we went back to where we were 2 weeks ago, we could be as low as this 2 months from now, which is, again, identical to the bad flu season of 2017, 2018. So here are the projections. I said, this is where we are today, half and another half. And this would be the number of people. If you remember this, this number for the next slide, it would be important. This roughly 1 in 4,000 folks. And of course, we'll generate the information that shows you how dramatically different the older population and the population with existing illnesses are relative to the younger population. But taking into account, that's the number you should pay attention to. But this is where we were into just basically 3 years ago. So 45 million people got sick from that particular influenza season, and understand that when epidemiologists say influenza, they do not mean one virus. There are collections of influenza viruses and other viruses, including coronaviruses, that make up what we call the flu season. But in that year, 61,000 people died, and 20 million people went to see doctors or healthcare providers. And, the rate of hospitalization was pretty high, and the death rate was very high. And so when you look at the number of where we intend to be at 1 in 4,000, 2 months from now, where we could be if we had a coherent strategy, here it's 1 in 5,000. So it's not dramatically different. And understanding that the problem with projecting where we'll be is that soon overlying on COVID will be our normal flu season, which won't peak their deaths until November to February. So this is going to soon overlap, and that's why it's important to get over the hysteria and deal with this more coherently before this overlap happens with the flu. So here we are, based on this data comes from 2018, but 650,000 and so on. So the reason we'll never know, in my opinion, what the true rate of COVID, of death due to the virus, is because in this mix here, 80% of the patients have this underlying disorder already. So how are you going to be able to tease out the difference between died from COVID versus died with COVID? But here we are right now. We're here at 150, and we may end up to be between 200 and 300, depending on where the country goes and how effective. Isolation, which isn't, hopefully at the end of this, we'll all understand why that may not be the most rational set of decisions. But right now, this is a number that also is important because, again, normally speaking, we'd be roughly, now we're only half through the year, but roughly this is the annual death rate from chronic lung disease. So here we are again, just to show that we're rising up. And the question is what is it going to look like in early September? Is it going to be up here? Is early October going to be up here and go right back up again? And I want to argue the fact that that's very, very unlikely to happen. And why do I feel pretty enthusiastic about that is because when you look at the sum total of the national information based on CDC data just literally less than 2 weeks ago, we're still at a rate of 8.6 to 9.6 of positivity rates. And when we have real flu epidemic years like 017, 018, roughly 30 to 40% of people will test positive for that particular virus. So this is a relatively low prevalence across the entire country. This is based on 4,000 or 5,000 data points across the country. And then ultimately looking at the ER visits, only 3.5% of ER visits are due right now to COVID-19. And 7 of the 10 regions are reporting only slight fluctuations. Now, that's not happening in Houston. Houston reminds us of what happened in New York. This is not happening in Austin, Texas. This isn't happening in Miami, Dade, and so on. There's certain hotspots that are ready to be overrun. Hospitals in Arizona are sending patients away to other states. There's no question about that. That's not a hoax, in my opinion, certainly, unless it's all made up. That's not likely, in my opinion. So then you say, but it's regional, it's not national. Like look in my hometown of San Francisco. We have a very aggressive, progressive, aggressive government, and our mayor has been very strict, and not that she had much to do with the success of San Francisco, because it largely came to do by allowing tech workers to stay at home very, very early on in March. But basically, we've never really had a surge in San Francisco. And you look here at the number of deaths, confirmed deaths, about roughly 5 weeks ago were 48, And 5 weeks, in this case, 4 weeks later, apologize, it's 51. So we've had 3 deaths in that month period, which is exceptionally low. And I know personally from my hospitals here that there are very few ICU beds taken. The hospital is now full. The hospitals are now full, but they're full of non-virus patients, although there are patients on the wards. There are also hospitals here in the city that use more progressive protocols, which include steroids and other things that I'll describe in a minute that allow one to get over this illness faster if you're going to get better. So this comes from the World Meter database from Hopkins, and this is the new confirmed cases. Now here, we're not testing very many people. We're only testing people in the hospital. We're only testing, this is about a month into it, in the middle of the peak, when most of the tests are all being done in the East Coast, and roughly at 30,000 some odd cases a day. And then it's flat, goes down, and then begins to rise a few weeks after Memorial Day, and then takes off. And then by July 4th, the second major massive opening, then it takes off even further. These are just new cases. That's all this is. Now remember that George Floyd was slain in this period of time here, and all this period here is including all the way to now we're involved in these protests, but the protests don't seem to have a clear measurable effect, although it may participate in the excess testing that's taking place here. But when you look at the new deaths, you see that relative to where we were before, we're in better shape, although again, right now we're rising, and we're rising because of 5 states, and we're rising, and we can't allow this thing to take off again. That would be untenable. But again, in terms of new deaths after the George Floyd event and after Memorial Day, they're going down, and they're going down dramatically. It's a 40% drop between over a 30-day period before we hit this bump. This is due to certain states updating their databases. It wasn't a real spike in one day, but the trend is still lower, and then it starts to rise. And here is where the issue is after July 4th, the death rates particularly in the 5 states start going up. And here it is again in higher power, but really shows you that this trajectory is a real trend, and it's a worrisome trend. But wearing masks is completely rational, and but going into lockdown mode, I will hope that all of you will recognize is not going to be hopefully necessary or productive, and the data will show it in a second. So here is in California, it's the new cases, because we're doing more and more testing, and from July 4th, we're actually flat in terms of new cases. So every state is going to be different. But when you compare the differences between, this is a country slide, all the way from the beginning of March into April at the peak. This is in normalized by population. So this is in the United States versus Sweden. And one of the fascinating things is they had a much higher peak, but we converged with them a few times. And over the 3-month period after they first started, we're converging here around 40 days ago, around the time that the early part of June. And then they get better than we do, and we're going in the opposite direction. So this is when restaurants are open and businesses are open and so on. And there are trends, but now the trend is in the opposite direction of the United States, which which doesn't have a uniform policy. So again, this goes back to where we were before, which just reminds us where we were in terms of pre-existing conditions. And the most important part of this particular slide is this. 80% of all the deaths. In this case, it was based on the CDC at the early part of the month. They only update their information once a month. So this is 114 some odd thousand deaths. Well, 80% of them are coming from this group. And when you look at below the age of 14, means these are the kindergartners, grade school, and middle school folks. There are a total of 26 deaths out of the 104,000 people that have been done, that were characterized as being with mortality, COVID-related mortality in early July. So it's an extraordinarily small number. And when you look at the ratios here, they're 1 in almost every 2 people that died was above the age of 75 versus 1 in 7 or 8,000. So what does this mean? The relative risks are obviously, we know about age, we know about pre-existing conditions. It also is regarding the region you live in. When you're in New York at the peak, you're in a high risk zone. And right now, if you're in Houston, you're in a high risk zone. In certain parts of Arizona, the same. But there is an issue of race and standard of living. Standard of living is clear. Race may be a surrogate just for other things, but also a surrogate for vitamin D levels. We understand that. And then are you exposed to high risk environments? Yes or no? I don't think that there's really significant amount of information out there as to what the benefits of true lockdowns really are. I haven't seen anything that's impressive or jaw-dropping in terms of the positive effects of doing that. I know that there's a lot of press in terms of negative effects, in terms of how it can negatively impact your immune system. But and all these things, I bring out obesity as it's obviously a pre-existing condition, but I do agree with folks that this is going to ultimately take over as the number 1 or 2 risk factor, and that's because it is associated with a high degree of inflammation to start with. So let's look at treatment, and that's been the biggest change over the last month with new information coming forward. So here's an article that came out in the not well-known International Journal of Infectious Disease that will come out in full article form tomorrow. So I'm going to read this thoroughly, but this one used hydroxychloroquine and azithromycin in hospitalized people at the Henry Ford hospitals, which have one uniform protocol. So there are 5 hospitals in Detroit have one uniform protocol. And hydroxychloroquine reduced mortality rates significantly in this population. So this is something that also these centers also use steroids, and one thing that they do really well is they start people on this right away, and this gets published in the International Journal of Infectious Disease. Whereas this particular paper, I don't want you to focus on please don't focus on the graphs, but focus on the title. This is the New England Journal of Medicine that came out a few days ago. And this one knocks hydroxychloroquine and says it doesn't work. When you look at this and you look at all the studies that talk about the fact that these likely don't work versus the ones that do, you see one trend. And the trend is that in this particular study, the average person got treated with these drugs 7 days after symptoms started. And if you understand the life cycle of a viral illness that then leads to inflammation, you realize that the time to start hydroxychloroquine is immediately after you have symptoms of the sore throat or fever or muscle aches and pains or the next day, shortness of breath of the following day. But if you're treating people very early in the acute viral stage, then that's the time to give them this. But this got a sour note because of junk science that was published by the New England Journal, and now the New England Journal is making up for their embarrassments by producing information that, again, is not that relevant in my opinion, because this is not the way it should be used. We will all have to wait until this type of a study gets published, which was also done from the University on the Health and the Henry Ford system, where the looked at the study with responders and healthcare workers, and actually, I even don't think that this is the perfect study design, because to me, the design should be, I have symptoms, I will get tested, I'll know whether I'm positive or negative, and then I'm going to treat myself with this very safe drug. And there are many anecdotes. I don't know if any of you saw the African woman doctor from Houston with 350 cases, all treated similarly, all with the primary care, with hypertension, diabetes, etc., with no deaths, all treated with hydroxychloroquine. That has to be published, and we have to share that and not get it suppressed. But then you have this thing with steroids, and you say, well, why in the world would steroids work? Well, steroids have always been part of the treatment for acute respiratory distress syndrome, which is roughly in the category of what's happening here with the sickest patients. And well, dexamethasone is clinically effective in a number of patients. This study will also be soon fully published, but it is suggestive that an anti-inflammatory approach is okay. It cannot work in everyone. You cannot save everyone. You cannot save folks who are irretrievably ill, but you should be able to get the majority of people down. And then you say, well, if steroids work and the majority of the effect has to be done in the lung, why don't we just give people inhaled steroids? And I think this has come up both in terms of anecdotes as well as now published studies that will come out. And in this particular BBC News report of a study that yet to be published, so it's called preprint, almost 80% of patients were affected by significant reductions in improvement in oxygen saturations, and hospital times were reduced significantly. But it's just not, there's no single cure-all for this, but this is the right approach to take, and was rational from the first minute. This is how I treated all people that called me, because in my clinic, I couldn't close down the clinic, and we don't have a primary care center, so we treated all our patients remotely. And then again, another set of studies, this is in as early as late June, so this is a month and 5 weeks old, where it's published. It says that this is a rational idea. And this is, anakinra is a cytokine blocker. As you know, you've heard the term cytokine storm. Well, this is a cytokine blocker, and this also works with very high levels of efficiency. And this was the study previewed by Dr. Fauci on the couch in the Oval Office, and then when it came out, it was underwhelming. That showed some reduction in hospital stay, but no reduction in deaths. But this is an antiviral, and the reason it may work really late is because there are viral particles in the lung still, even late on, but it's not the primary way to get people better faster. The people get better faster if you have an anti-inflammatory approach. So I don't have time to get into this, but there are immune profiles that are now coming up, and you can predict who's going to be sicker than others when you go in, even before you're in the hospital. And this information will be useful for all of us in the future. There'll be some silver lining here to understand distinct types. But there are also types that are significant here in the sense that some of the folks that don't get as sick don't ever develop antibodies. So they're going to be very difficult to move on a vaccine. They're going to be difficult to stimulate on the vaccine side. And so the vaccine is never going to provide uniform protection to everybody. That's not possible. But hopefully we will have a rational set of vaccines in the future. But when that will be is completely unknown. And I want to make that clear. I won't get into it in detail tonight, but I will make it clear, I think, that it's not a rational perspective to count on. So what is rational? And the immune modulation is the key. And this has been published 2 months ago already in The Lancet, which is one of the top tier journals that also has a lot to make up for in terms of the junk science that they've been publishing. So what does that mean? Okay, and I've talked about this, and the Federal Trade Commission has taken down most of my posts on the website. Asked me to, otherwise you'd pay a big fine, and taken down all my YouTubes that talk about this. But this is just rational stuff. I'm not giving you individual medical advice, nor am I saying that all this has been shown. This is just strategy. It's a strategy of thinking about, what do I need in my body? Well, I need I need a regulatory vitamin that it's really a regulatory hormone. I need antioxidants like vitamin C. I need antivirals like vitamin A and zinc. I need, I could benefit from an antiviral that seems to work in all other viruses and may work in coronavirus too. More likely than not will, but it's not been shown. And that's something you can gargle with and spit out and get your viral titers in your throat lower. But all of these things, including antioxidants and so on, can help. I think but these top tier ones, these first 5 or 6, will more likely than not help reduce the viral load as well as the reaction to it. But what we really need is a deal. This would be a game changer. Is proving that there is a therapy. There is a therapy that's been shown to be effective in Asia. This is an antiviral, much like hydroxychloroquine, but they haven't published it yet. And this comes from my colleagues in Japan. And Japan has enough for their entire population, ready to go. The dexamethasone, the steroid data are encouraging. The oral inhalers are. This is fairly discouraging, but it will save some lives in the future. Statins, which are anti-inflammatory, these are the lipid drugs. And then all these other things that most of the integrative doctors in the United States and integrative dentists know about, and this is what we teach them when we have our joint courses. So here's an article published in Lancet a few weeks ago that is a cartoon. And if you can see it, you see all the different types of pathways, and these are all inflammatory pathways. You can produce 1,000 different cartoons, but these are where you can insert these different therapies. I'm not going to review this point by point, but this is a picture of an air sac, and this is the blood vessel. And there are problems within the blood supply. There are problems in the cell that ultimately lead to these lymphocytes getting excited through these cascades. And the question is, how do you tone it down? Well, you can use any variety of different things. It depends on what's available. But you can all have glutathione. You can all get that. You can go get vitamin C orally or now in hospitals intravenously. And you can get these things as long as you have a healthcare provider that can work with you. But if you look at this is not present in the Lancet article, of course, but it's all going to be involving both the lung as well as the cytokines. And so we've added other things like peptides and so on. These are basically communications networks. These are communications networks that tell the immune system to tone itself down. You're going into an exaggerated mode and stop it. And then you're modulating it with these variety of different things, and includes a diet, includes fasting, includes daily exercise, all of these things. And then you also have to take into account the fact that in the worst case scenario, this will thrombose your smallest blood vessels in the body, and that's a very late stage thing. So you have all these different therapies that are now helping reduce the mortality rates across the country, even under standard of care in the major hospitals, let alone if you have an integrative doctor working with you. But what's happening is you get permanent lung injury in the patients that have been under intubation. You get malnutrition, deconditioning. It's a mess to be in the hospital, as anyone well knows, for more than a few days. And then something that I'm supposed to be one of the experts on, this concept here. And when you get the virus and you leave it unchecked in your system for a period of days or weeks, you may develop autoimmunity later on in life, usually in the first 6 months, and that will primarily affect your heart and brain. So you don't have to stay away from a virus to stay away from this. You have to stay away from a lack of any strategy. So then we all know now the big debate is with children. We all know that the children are very at low risk, and about a quarter of the teachers and staff in the schools are at risk. And the question is, how do you solve this problem? And I'm not, going to argue one way or another. I just think that there are many countries around the world that are solving the problem, and we don't have time to review this, but we'll post this online. But it's very, the risk is extremely low for the children, but the children around the world are being allowed to go back to school, and of course there are little mini flares that you have to learn to live with, and zero tolerance is not going to work. And then you have this thing with children, and I don't have time to deal with this. It's rare, and it's probably an autoimmune state. So we should prepare by focusing on us. The virus is not going to go away. We have to deal with our own immune modulatory strategy that is good for us, whether it's viral focused early, and then it has to be anti-inflammatory later to remain asymptomatic or low-level symptomatic. How late will your immune system be able to remain stimulated? How long will you be immune for? I haven't seen any real information on the fact that it's going to be limited. It should reflect all the other viruses, and you should have extensive period of time where you're immune. But now they're already floating the ideas of the need for multiple vaccine boosts as well as annual boosts, which I don't feel there's any data for and suggests a bias. We do have better testing. This is like the pregnancy-like test. I don't have time to review that either. But it's not a surprise that with more tests you have more cases, but with more tests you have a lot more control over what's really going on, and understanding that this is a very, very common illness and probably is present in 10 times the population that currently is testing positive. So this is what you get from the establishment. This is the American Association for Medical Colleges, and you get the same old stuff. And to me, when you read this, I don't find this extremely helpful because there's nothing about inform, educate, and engage the public to really give me a rational idea what is my risk and what am I supposed to do. I would rather end with the following. Here's an analysis. It's the clearest wake-up call that our lifestyle and our medicines don't protect us. We're highlighting that we have too much inflammation in our bodies. This virus is not going to just go away. And that's clear from everywhere in the world. And then we have to empower ourselves and get our health in order. That's the best single protection. And that's what we should focus on the high-risk populations on, and certainly the elderly and so on should be focused on this. And we have to learn to live with this and understand that a zero tolerance is not. So acceptive health to protect our healthcare systems from being overwhelmed. And we need much more surgical set of interventions and a zero tolerance approach. But really, the most important thing here is the reality that in 3 months' time, we begin, by the 4th month, by another 100 days or so, we begin the formal flu season. We're not preparing for it. We're not anticipating a second wave of, had nothing to do with COVID, just a second wave of flu-like illness, which may be giving us anywhere from 10 to 60,000 additional deaths. We just don't know. We can't predict that. And that's why waiting for a vaccine is not a rational strategy. It may be effective. We may have one, we may not. It may take a year or two to get it throughout the population. And these are all important points, but I think that an oral drug that can be treated early with is still the best chance for us to get a complete handle on this and reduce deaths and complications very rapidly. But our current standard of care involving these other things are already having our mortality rates and probably will continue to do that. So if we transition to a quarter of our current mortality rate in the next 2 months, then we'll get to a point where we follow the father of internal medicine in the United States and say that right now we don't want 20 drugs for each disease. We want one strategy for many diseases, and this virus affects 20 different systems, and we have a strategy, a uniform strategy to deal with it. So thank you.